Greetings, everyone. So since I am busy this Saturday, I have created this video for you as a substitute for our Saturday review, and I've based it off of a lot of the questions that Dr. Lobo has sent you as review questions leading up to your midterm. You will also have access to this PowerPoint. I'm going to send this PowerPoint as well to your class rep so that you will have access to both the PowerPoint and this video to help you review in preparation for your test. I've gone ahead and listed all of the videos that I've recommended in previous slides in order for you to have them as reference in case you want to go back and use a video to review. So let's get started. We're going to start with upper limb innervations. And obviously, because this is a review, a lot of the stuff you're going to have heard before, but I'm just going to say it again so that you have this and you can study it, go back, rewind, press play as you will. So hopefully this will be helpful for you. So if we're going to talk about upper limb innervations, of course, we have to start with the brachial plexus. There are 5 parts of our brachial plexus. The mnemonic that I used when memorizing the parts of my brachial plexus was read the darn cadaver book. This is referring to the roots, the trunks, the divisions, the cords, and the 5 terminal branches of the brachial plexus. The roots of the brachial plexus are C5 to T1, and these are the most common roots of the brachial plexus. The trunks of the brachial plexus are superior, middle, and inferior. The divisions are anterior and posterior, and they are in relation to your subclavian artery, as opposed to the cords, which are lateral, posterior, and medial, which are in reference to your axillary artery. And then finally, your 5 terminal branches, your musculocutaneous nerve, axillary nerve, median nerve, radial nerve, and ulnar nerve. So looking at the brachial plexus in more detail, just remember that you're going to need to be able to identify any of these nerves shown here. As you can be tested on them. They will absolutely have a blank brachial plexus, and you'll need to be able to identify what nerve it is based off of a patient coming in with some sort of weakness or a loss of sensation, and then you'll have to be able to pick which branch is the problem. So again, we can see our roots C5 to T1, and there are 2 nerves that come directly off of the roots. You have your long thoracic nerve, which pulls fibers from C5, C6, and C7. Your long thoracic nerve innervates serratus anterior. And recall that when we have damage to the long thoracic nerve, we end up with wing scapula because our serratus anterior has been paralyzed. The other nerve that comes directly off of the roots is your dorsal scapular nerve. And your dorsal scapular nerve helps to innervate your rhomboids as well as part of your levator scapulae. Next, we have our 3 trunks, superior, middle, and inferior. Again, 2 nerves are coming off of the trunks. You have your suprascapular nerve coming off before it heads into the suprascapular notch. And then your nerve to subclavius, which is going to go and innervate your subclavius muscle. Here are your divisions, both anterior and posterior. We make note of these so that we can better understand how the fibers of the brachial plexus are traveling. Recall that I've mentioned this before, nerve fibers tend to just go forward. So we can understand how C5 and C6 are just going to go forward, but then some of those fibers can then come down here into the posterior cord and end up in some of our terminal branches over here. No nerves come off of the divisions. However, quite a few nerves come off of the cords. We have our lateral, posterior, and medial cords. So the first thing I want you to notice is how you have your lateral pec nerve as well as your medial pec nerve. Lateral pec coming off of the lateral cord, medial pec coming off of the medial cord. And then this branch in between the two, connecting the two, this is our ansa pectoralis. So lateral pec, medial pec, ansa pectoralis. 2 other nerves come off of your medial cord. They're both for cutaneous innervation. You have the medial brachial cutaneous nerve as well as the medial antebrachial cutaneous nerve. Whenever you see the word antebrachial, I want you to think of forearm. So medial antebrachial cutaneous nerve right here, along with your medial brachial cutaneous nerve. Now looking at our posterior cord, we have 3 nerves coming off of the posterior cord, and the way I remembered them is that they all have something to do with subscapular. So this nerve, which is the most proximal of the 3, it's up above, and I put that in quote buddies, up above the other 2. So this is our upper subscapular nerve. This nerve, which is below the other 2, so it's lower than the other 2, it is our lower subscapular nerve. And then finally, this nerve that's in the middle, you could call it the middle subscapular nerve, but most people don't actually call it middle subscapular. This is your thoracodorsal nerve. And finally, looking at your 5 terminal branches, you have your musculocutaneous nerve coming off of your lateral cord. Coming off of your posterior cord, you have the axillary nerve branching off to go innervate deltoid and teres minor. And you also have the radial nerve to innervate all of those muscles in the posterior aspect of the upper limb. So you can see here how the lateral and the medial cord come together to form the median nerve. Yes, it is annoying that we have a median nerve and a medial cord and a middle trunk. Do your best to try and remember those and keep those differentiated in your head. I know it can be confusing. The median nerve is a terminal branch of your brachial plexus. And then finally, this extension from the medial cord, this is your ulnar nerve. So make sure you practice your brachial plexus. Lots of questions about this. Okay, so now let's talk about sensory innervation of the upper limb. We already mentioned how axillary nerve is innervating your deltoid muscle and your teres minor muscle, while it also innervates a skin overlaying part of the deltoid muscle, and there's going to be a better picture of that coming later on in this PowerPoint. Notice here on the anterior aspect of your arm, how even the radial nerve, even though it's mostly doing posterior cutaneous innervation, it does still have some cutaneous innervation on the anterior aspect of the arm. So recall our medial brachial cutaneous nerve, which came directly off of the brachial plexus. You can see here how it is giving cutaneous innervation to this medial aspect of the proximal upper limb, both anteriorly and posteriorly. Continuing further down, further distally, you can see how on this anterior portion of the upper limb, you have the lateral antebrachial cutaneous nerve, which is the terminal branch of your musculocutaneous nerve. You also have the medial antebrachial cutaneous nerve, which came directly off of the brachial plexus. So this is the anterior aspect of your forearm. On the posterior aspect of your forearm, again, you have medial antebrachial cutaneous nerve, as well as lateral antebrachial cutaneous nerve, but you also have posterior antebrachial cutaneous nerve, which is a branch off of radial nerve. Looking down into the hand, and actually I think I have a better slide for this here. You can see how cutaneous innervation for the hand is going to involve the median nerve, the ulnar nerve, and the radial nerve. So on this palmar surface, you can see how cutaneous innervation is split between your median nerve and your ulnar nerve, and the split goes through the ring finger. On this dorsal side of the hand, you can see how there's a split between ulnar nerve and radial nerve, and that is at the middle finger. However, notice how all of the fingertips, radial is not involved in any fingertip cutaneous innervation. It's always going to be either median nerve or ulnar nerve. However, do not forget that radial nerve is going to give you cutaneous innervation on this proximal portion of the thumb, both on the anterior and posterior aspects of the proximal thumb. Okay, so just to review some innervations of muscles that I've mentioned before coming off of the brachial plexus. So we're just going to go through these to help you quiz yourself. And obviously you can use this PowerPoint as flashcards to help you practice your muscle innervations for later. So lateral and medial pectoralis nerves are going to help you innervate your pectoralis major and minor. Your dorsal scapular nerve is going to innervate your rhomboids, major and minor, and gives some fibers to levator scapulae. Your suprascapular nerve is going to innervate your supra and infraspinatus muscles. Your upper and lower subscapular nerves are going to innervate your subscapularis muscle. Your lower subscapular nerve is going to innervate your teres major muscle. Your thoracodorsal nerve innervates your latissimus dorsi. When I need to remember this particular one, I just think of that dorsal, dorsi, how they have that in common, and that helps me to remember that. Your long thoracic nerve innervates your serratus anterior, and your axillary nerve innervates your deltoid and teres minor muscles. And then we're going to see the cutaneous branch coming up in just a moment. So your rotator cuff muscles, let's talk about them. You have 4 rotator cuff muscles that are there to provide support and flexibility to this clinohumeral joint, the joint between your humerus and your scapula. I love these pictures that show you color-coded the origins and insertions of different muscles. This is just one of the ways that help me to remember the actions of the muscles by visualizing where do they start, where do they end. We pull wherever they end towards where they start. So you can see here, here's your subscapularis muscle. Here is your supraspinatus here, as well as here. Here's your infraspinatus muscle. And then here's your teres minor muscle. And again, these are our rotator cuff muscles, and the mnemonic that we use is SITS, supraspinatus, infraspinatus, teres minor, and subscapularis. So it's important to note that when it comes to your rotator cuff, the reason why we have these muscles there is to give us flexibility and stability. However, the more that you increase flexibility, you end up decreasing stability. And the more you increase stability, you end up decreasing flexibility. So you're trying to give a balance between flexibility and stability at this particular site. So at this joint. Now, I want to reiterate this. Teres major is not a rotator cuff muscle. This is how they trip up people all the time in questions. You go too fast and you see teres and then you click teres major instead of minor. Teres major is not a rotator cuff muscle. Other thing I wanted to make note of, because I vaguely recall this being like a question that I had at one point. So the only rotator cuff muscle that medially rotates is subscapularis. Subscapularis is the only rotator cuff muscle that does medial rotation. Both infraspinatus and teres minor do lateral rotation, and supraspinatus is for initiation of abduction and then works with deltoid muscle to help to abduct the arm. Okay, so axillary nerve. Here is the picture I was talking about that's showing you the cutaneous innervation over the upper limb, right where the deltoid is. You can injure the axillary nerve if you fracture the surgical neck of the humerus. You can have injury during intramuscular injections of drugs. You can injure it if you have a dislocation of the glenohumeral joint. And you can injure it if you have incorrect use of crutches. And so it ends up with like a compression injury here. So now we're going to talk about nerves, excuse me, the terminal branches coming off of the brachial plexus and the muscles that they innervate. So musculocutaneous nerve, and this is a really good picture to show this, it pierces through the coracobrachialis muscle, and it innervates coracobrachialis, brachialis, and biceps brachii in the anterior proximal arm. And remember, the terminal branch is the lateral antebrachial cutaneous nerve, which gives you cutaneous innervation on the lateral aspect of the upper limb. Median nerve innervates most of the muscles of the anterior forearm, except for flexor carpi ulnaris, which that should help you, the fact that ulnar is in the name, so you know that it's innervated by ulnar nerve. And then the ulnar half of flexor digitorum, that should be profundus. I don't know why I put superficialis. Yeah, let me fix that right now. There we go. So the ulnar half of flexor digitorum profundus is innervated by ulnar nerve. All the rest of the muscles in the anterior forearm are innervated by median nerve. And then in the hand, median nerve innervates the first and second lumbricals as well as the muscles of your thenar eminence. I love this plate and netter because it's literally showing you all the different muscles that it innervates, as well as the cutaneous innervation over the hand. So this is median nerve. For ulnar nerve, it innervates that 1.5 muscles in the anterior forearm, so flexor carpi ulnaris, as well as the ulnar half of flexor digitorum profundus. See, I put it correctly on this slide. And then it also innervates the intrinsic muscles of the hand, except for the first and second lumbricals in your thenar eminence. So ulnar nerve is going to innervate the hypothenar muscles, your third and fourth lumbricals, your adductor pollicis, your palmar interossei, your dorsal interossei. So lots of muscles that ulnar nerve innervates in the hand. And then here's your cutaneous innervation of the hand. So radial nerve does innervation on the posterior aspect of the upper limb. So obviously your triceps muscle on the proximal upper limb. And then the posterior forearm muscles, so the extensors of the upper limb, the extensors of the hand. And you can see cutaneous innervation here in red from radial nerve. So a note about supination versus pronation. So the action of pronation is crossing the radius over the ulna. So here's your ulna, the bone, here's your radius, the bone. Pronation is crossing the radius over the ulna, and then supination is bringing them back to this position. So you actually have this movement happening with pronator, teres, and supinator, how the two of them have opposite actions and they roll against one another here at this juncture between your radius and your ulna. And it's like spinning a branch to light a fire is the rolling action that happens. Here's another really good picture to show you supination versus pronation. So to get pronation, you have contraction of your pronator teres and your pronator quadratus, which you can see pronator teres, pronator quadratus. They are pulling their insertion towards their origin. They cause pronation. Versus for supination, you have the supinator and the biceps brachii. When they contract, they pull that radius back in a line with the ulna. So you can see how it's coming back over to straighten them out. So pronation versus supination. Now, making a note about the branches of the radial nerve. Depending on how specific your professors want to get, the radial nerve does have branches, both superficial branches. So the superficial branch of radial nerve for innervation of the skin on the posterior lateral surface of the hand, as well as deep branch of radial nerve and posterior interosseous nerve for innervations of the muscles in the deep layer of the posterior forearm. I went ahead and included both this picture here to help you, as well as this chart to make distinctions between what radial nerve branches innervate what muscles. So radial nerve itself innervates your brachioradialis, your extensor carpi radialis longus, as well as the triceps muscle. Deep branch of radial nerve is going to innervate your extensor carpi radialis brevis, your extensor digitorum, your extensor digiti minimi, and your extensor carpi ulnaris, as well as your supinator. And then your posterior interosseous nerve is going to innervate your extensor indicus, your abductor pollicis longus, your extensor pollicis longus, and your extensor pollicis brevis. I'll make a note, we're going to talk more about the anatomical snuff box, but these are the 3 tendons that give you the borders of your anatomical snuff box. So hopefully that will help you remember them in association with posterior interosseous nerve. Okay, so nerve injuries in relationship to fractures of your humerus. So we have to know the 4 spots where we could possibly injure a nerve if we fracture our humerus. If we fracture the surgical neck of the humerus, we can damage our axillary nerve along with the posterior circumflex artery that's running with it. If we fracture the shaft of our humerus, we can damage the radial nerve along with the profunda brachii, the deep brachial artery. And these are running on the posterior aspect of the humerus. So that's why it's in shadow here. If we have a fracture of the supracondylar region, supra meaning above, condylar meaning the epicondyles here, your medial and your lateral epicondyles. If you break this area above them, you can injure the median nerve as it travels through your cubital fossa along with your brachial artery, which is also traveling through your cubital fossa. And if you fracture your medial epicondyle, you can damage your ulnar nerve, which is passing posteriorly behind your medial epicondyle as it travels down into the forearm. So now we're going to talk about upper limb blood. So blood supply to the upper limb. So you can see here your subclavian artery. I'm just going to mention this. When it comes to blood supply, it would be helpful if you remembered it starting from the heart. So starting from the heart, blood is pumped out of the aorta into the aortic arch. And the first branch off of the aortic arch is the brachiocephalic artery. You only have one brachiocephalic trunk, and that's on the right side. On the left side, your common carotid, your left common carotid and your left subclavian come directly off of the aortic arch. So that's why you end up seeing a lot of blood supply being shown for the right upper limb because it has that brachiocephalic trunk. So the brachiocephalic trunk then splits into your subclavian artery and the right common carotid artery here. So your subclavian artery then continues on as your axillary artery, and we make the delineation between the two at the lower border of the first rib. So subclavian artery turns into axillary artery when you pass by this lateral margin of rib number 1. So your axillary artery is here, and it has 3 parts. And these are all in relation to your pec minor muscle. Part number 1 is before your pec minor. Part number 2 is deep to your pec minor. And part number 3 is after it is passed by your pec minor. And then your axillary artery turns into your brachial artery once you have passed the lower border of your teres major muscle. So the boundaries of your axillary artery are the lateral margin of your first rib and the lower border of your teres major. So breaking down blood supply even further, the first part of your axillary artery has 1 branch, that is your superior thoracic artery. The second part of your axillary artery has 2 branches. First, we have the thoracoacromial trunk. The thoracoacromial trunk has 4 branches coming off of it, and we remember those 4 branches by the mnemonic DCAP, which stand for deltoid branch, clavicular branch, acromial branch, and pectoral branch. The second branch coming off of the second part of your axillary artery is your lateral thoracic artery. And then your third part of the axillary artery has 3 branches coming off. The first one is your subscapular artery. Your subscapular artery then splits into 2. You have your circumflex scapular artery, and then your thoracodorsal artery. The second branch that comes off of the third part of your axillary artery is the anterior circumflex humeral artery. And then the third branch is the posterior circumflex humeral artery. You can see how the two of these circle around the surgical neck of the humerus and anastomose with each other. So it's the circle of vasculature for blood supply to the surgical neck of the humerus. Now, the scapular anastomosis. So the scapula is an oddly shaped bone. It's triangular. It has parts coming off of it. So this is the spine and then continues around to the acromion. It's funky shaped. It's interesting. It's helpful. So because it is shaped this way, we actually have a network of blood supply that goes around the scapula to make sure the bone stays enriched with blood. So the scapular anastomosis includes suprascapular artery, which came off of like as a branch from a branch off of your subclavian artery. So it was like thyrocervical trunk and then suprascapular artery. You have your circumflex scapular artery, which we can recall comes from your subscapular artery that came off of that third part of your axillary artery. And now, depending on what source you use, some people will say that it is the deep branches of the transverse cervical artery that contribute to the anastomosis around the scapula, or the dorsal scapular artery that contribute to the anastomosis around the scapula. So just go with whatever your professor wants. See, because this is from, so this picture was from Gray's Anatomy, and this picture was from Netter, or yeah. And then this picture is from your Moore textbook. So ask your professor which one they want you to know. But you need to know these different arteries because if you compress this portion of your axillary artery, the anastomosis around the scapula is one way for blood supply to get from your axillary artery to your brachial artery and then down into your upper limb. And so the blood would end up going around the scapula, going into the circumflex scapular artery, and then going back into the axillary artery via your subscapular artery. Okay, so now let's talk about the brachial artery. So here's your brachial artery, and then I've gone ahead and put stars by branches that are important for you to know. So your brachial artery starts at the lower border of your teres major. The first branch that comes off is the profunda brachii, also known as the deep brachial artery. And I'll just make note that you can see here, there's actually an ascending branch coming off of profunda that anastomoses with the posterior circumflex humeral artery. So this is the one way that if you cut off blood supply to the brachial artery after anterior and posterior circumflex humeral arteries, you can still get the blood supply to go down into the upper limb via this anastomotic branch coming off of profunda. Profunda brachii then later, as it's traveling down, splits into the radial collateral artery as well as the middle collateral artery. If you ever see the word collateral, a collateral artery is an artery that's running in the same direction from the main artery here. So your main artery is your brachial artery, and then your radial collateral and middle collateral arteries are running, like their blood is running in the same direction as the brachial artery. So the next branch coming off of your brachial artery is your superior ulnar collateral artery. So superior because it came off above the inferior. If you have a superior something, there's usually an inferior something. Just like if you have a longus, there's usually a brevis. If you have an anterior, there's usually a posterior. That's just something like to keep in mind to help you organize information. So just to reiterate, our brachial artery, our profunda brachii splitting into radial collateral and middle collateral, our superior collateral artery, and then our inferior collateral artery. As the brachial artery travels down, once it gets into the forearm, this is around the area of your cubital fossa, it splits into your radial artery and your ulnar artery. Now, your radial artery and your ulnar artery have branches of their own. For your radial artery, its branch is the radial recurrent artery. If you ever see recurrent in the name of an artery, that is a arterial blood vessel where the blood is running opposite direction of the main branch. So see how brachial is running down, radial is running down. Well, radial recurrent goes back up. So blood is flowing in an upward direction as blood is flowing down the brachial artery. So radial recurrent sends blood back up. Next, we're going to look at our ulnar artery. So our ulnar artery has its first branch as the anterior ulnar recurrent. Anterior because it's going to travel in front of, anterior to this medial epicondyle. Ulnar because it came off of the ulnar artery, and recurrent because the blood is traveling in the opposite direction of our main branch, of our main arteries. The next branch is our posterior ulnar recurrent. So the posterior ulnar recurrent travels behind this medial epicondyle. It's branching off of the ulnar artery, and it's recurrent because the blood is going in the opposite direction of the main artery, the brachial artery. And then the third branch of the ulnar, off of the ulnar artery, is your common interosseous artery. The common interosseous artery is pretty short. It then splits into two. You have your anterior interosseous artery and your posterior interosseous artery. Excuse me. The two arteries are separated via this interosseous membrane that is in between your radius and your ulna. There is also the recurrent interosseous artery. Again, a recurrent artery is going in the opposite direction. The blood flow is flowing in the opposite direction of the main artery it comes off of. So this is your recurrent interosseous artery. So now we're going to talk about the anastomosis of blood supply around the elbow. And I've already mentioned all of the blood vessels that are involved in this anastomosis. The mnemonic that we use to remember this is simmer pair. Simmer is all of your collaterals involved, pair is all of your recurrents involved, and each collateral is paired up with a recurrent. And you can see how I've highlighted here your collaterals with your recurrents. So your superior ulnar, and this is going medial to lateral as well. Your superior ulnar collateral artery anastomoses with your posterior ulnar recurrent artery, which you can see here. Your inferior ulnar collateral artery anastomoses with your anterior ulnar recurrent artery, which you can see here. Your middle collateral artery anastomoses with your recurrent interosseous artery or interosseous recurrent artery, whichever one you want to say. And then your radial collateral artery anastomoses with your radial recurrent artery. So that one's easy, radial with radial. Now we're going to talk about the blood supply in the hand. So the blood supply in the hand represents an anastomosis between the ulnar artery and the radial artery. You can see how they've traveled down the forearm, and now they both are giving blood supply to your superficial and deep palmar arches. The superficial and deep arches both then branch and anastomose as the common palmar digital arteries, and then branch again to give blood supply to the individual digits as the proper palmar digital arteries. Other important branches that we can see here. So as your radial artery continues, it gives off a branch to the thumb known as the princeps pollicis artery. It also gives a branch to the lateral aspect of the index finger called the radialis indicus artery. And then both the radial and the ulnar artery give branches to the dorsal carpal arches on the posterior aspect of the hand. as well as your anterior and posterior interosseous arteries come back together, they anastomose back together and give blood supply to the posterior carpal arch as well. When it comes to the veins of the upper limb, you have superficial and deep veins as well as veins associated with the hand. So for your superficial veins, you can see how you have your basilic vein here, your cephalic vein here, and they are connected by the median cubital vein. The median cubital vein is in your cubital fossa, and this is usually where you get blood drawn when you go to the doctor. So your deep veins are your ulnar vein here and your radial vein here, which are obviously paired up with the arteries of their same name. They come together to form the brachial vein, and the brachial vein empties into or combines with the basilic vein in order to create the axillary vein. The cephalic vein empties into the axillary vein, and together they make the subclavian vein. And then the subclavian vein joins with the internal jugular vein to create the brachiocephalic vein. And you have two brachiocephalic veins that when they join together, they create the superior vena cava. And the superior vena cava empties directly into the heart. So you have two brachiocephalic veins, but only one brachiocephalic artery, and that's for the right upper limb. So the veins associated with the hand are named just like the arteries, so you have a superficial and deep palmar venous arches. So now we're going to talk about the carpal bones. So you have 8 carpal bones. You need to memorize their names. You need to be able to recognize them on a picture. You need to be able to recognize them on an x-ray. So I learned them as, lateral to medial and proximal to distal. So you have your scaphoid, your lunate, your triquetrum, your pisiform, your trapezium, your trapezoid, your capitate, and your hamate with its hook. This is the anterior aspect of your carpal bones. On the posterior aspect, you do not see pisiform and you do not see the hook of hamate. Both of those are on the anterior aspect, on the palmar aspect of your hand. Make sure you know ossification timing. This is a very easy question for them to throw at you. So just remember hamate and capitate ossify first, pisiform ossifies last, and get a general idea of all the others in between. Because I don't know how specifically they'll question you on this, but this is a very easy question to throw out. And this is a fairly good x-ray to help you identify the bones. So breaking your carpal bones, so fractures of your carpal bone as well as dislocation. Your scaphoid is the most frequently fractured carpal bone. This can be because of a Fuchs injury, you're falling on an outstretched hand, especially when it's abducted. And it can lead to avascular necrosis because if it's not caught in the ED and they don't splint your finger, it won't realign the bone, so blood supply can't be returned to this portion of the bone, and then it can die in as little as 10 to 14 days. And it might not show up on an x-ray immediately. Versus your lunate carpal bone is the carpal bone most often dislocated and is always anteriorly. So here is a dislocated lunate. It should not be this far forward. It should be in line with the other carpal bones. Here is a fractured scaphoid bone. And then here are fractures of your hook of hamate. If you fracture the hook of hamate, you can damage the ulnar nerve and artery because they do run pretty close to where that hook of hamate is. Okay, so I'm going to talk about the axilla now. So the axilla is a major passageway of blood, nerves, and muscles going towards the upper limb, into and out of the upper limb. It has boundaries that you're going to want to be pretty familiar with because they can ask you questions about the boundaries. I really like this picture when it comes to, first I like this picture when it comes to visualizing the axilla, and then I like this picture when it comes to naming the different boundaries of the axilla. So I made it bigger for you. So you have your medial wall, which includes your serratus anterior, your ribs and the intercostal muscles. You have your anterior wall, which includes your pec major, your pec minor, and fascia. You have your posterior wall, which includes your subscapularis, your scapula, your teres major, and your latissimus dorsi. And then you have this intertubercular sulcus of your humerus, which is the lateral wall. So this is your axillary borders. You also are going to need to know the lymph nodes that are in this area and how they flow, how they're arranged with each other. I really like this graphic depiction of your lymph nodes to help you understand drainage. So you have your pectoral lymph nodes, which you can see right here, which are also known as your anterior lymph nodes. You have your humeral lymph nodes, which are also known as your lateral lymph nodes, and they're draining the upper limb itself. You have your subscapular lymph nodes, and you can see your subscapular lymph nodes, which are also known as your posterior lymph nodes. And so all these groups of lymph nodes are draining into your central lymph nodes. You can see humeral, subscapular, pectoral, draining into central, humeral, subscapular, pectoral, draining into central. And then central drains into apical, central draining into apical. And then apical drains into supraclavicular lymph nodes, supraclavicular lymph nodes. So you got to know this arrangement and understand the flow of lymph from these nodes. Okay, so now let's talk about some clinical correlations. So first off, your cubital fossa. You're going to need to know that your cubital fossa is important because of this median cubital vein, how it is the most common site for venipuncture, for drawing blood. And if the phlebotomist makes a mistake and goes deep, it can damage the structures that are underneath. The borders of your cubital fossa include its roof, which is the bicipital aponeurosis, the floor, which is the brachialis and supinator muscles. So there's supinator, and I can't, where is brachialis? Brachialis would be up here because it's hugging on the bone. So probably right there. The lateral border is your brachioradialis, which you can see here. And then the medial border is your pronator teres. Now, you're going to need to know the contents of your cubital fossa. When I was memorizing them, I made up the mnemonic Robin beats Batman, and this is lateral to medial. So Robin standing for radial nerve, beats standing for biceps tendon, bat standing for brachial artery, and then man standing for median nerve. Robin beats Batman. Radial nerve, biceps tendon, brachial artery, median nerve. Next, we have our anatomical snuff box. So you can see that right here. You're going to need to know the borders of your anatomical snuff box, which are 3 separate tendons. And I've highlighted them with these red stars. So your extensor pollicis longus tendon, your extensor pollicis brevis tendon, and the abductor pollicis longus tendon. So those are your borders. Then you're going to need to know the contents of your anatomical snuff box, which I highlighted with these black stars. So going superficial to deep, you have your radial nerve dorsal digital branch. Then you have your cephalic vein branches, which unfortunately are not shown. They cut them away from here. Then you have your radial artery, which you can see here, your scaphoid bone, your trapezium, and the base of your first metacarpal bone. So scaphoid, trapezium, first metacarpal. When it comes to taking a person's pulse, you can get a radial pulse by using your index and middle finger and pressing them. You can feel the pulse lateral to the flexor carpi radialis longus tendon. When it comes to subluxation, this is a pretty common thing with children. So subluxation happens when you have popped the head of the radius out of the annular ligament. You'll have a common history where a child is suddenly lifted or jerked up by the upper limb while their forearm is pronated, i.e. you're lifting up a child. And actually to fix this, you like supinate the arm and then like flex it, and that should usually get it back into place. So this is what's normal. And you can see here's your annular ligament. You can have subclinical subluxation where it comes out a little bit, but it doesn't, like the head doesn't come out all the way. Full subluxation where the head comes out, but it's still in alignment with the humerus. And then dislocation is when the head has come out of the annular ligament. It is now moved lateral to the annular ligament. So this is dislocation versus subluxation and still in a line. When it comes to your Colles fracture versus your Smith's fracture, your Colles fracture is way more common. Both of these are examples of your Fuchs injuries falling on an outstretched hand. For your Colles fracture, your distal portion of your radius is displaced posteriorly, so you end up with what's called the dinner fork deformity. Versus for Smith, it's just the reverse Colles where the distal fragment is displaced anteriorly, but Smith is less common. Colles is way more common. Or Colles. Never know how to pronounce that. Okay, so elbow tendonitis or a lateral epicondylitis. So that's a painful musculoskeletal condition caused by repetitive use of the superficial extensor muscles of the forearm. When it comes to fracture of your olecranon, that's fracture of your elbow. So what ends up happening is that it's often caused by a fall where the person has a sudden powerful contraction of their triceps. So they're trying to like brace themselves through the fall. They contract their triceps. So you have both the force of gravity pulling your arm down and the hit there, as well as the force of the triceps tendon pulling against this olecranon. So you get the crack here and the pull all at once. So that's how you can get an avulsion. Like it avulses off, it gets ripped off. And you're gonna see, you should be able to see like the protrusion underneath the skin, like it's not gonna look correct. So that's fracturing your elbow, fracturing your olecranon. And now I wanna talk about or compare and contrast your tennis elbow versus your golfer's elbow. So for tennis elbow, think of when a person is doing a backhand. So when they're doing a backhand, they're extending their forearm. So this is from chronic inflammation or irritation, so basically overuse of your extensor muscles. So you end up with lateral, you have pain at the lateral epicondyle because of overuse from extension, overuse of the extensor muscles. As opposed to golfer's elbow, think of when a golfer is going and making a swing to like hit off of the tee. So that's flexion of your forearm. So this is overuse of your flexor muscles. So you're going to end up with pain at the medial epicondyle because that's where your common flexor tendon is. So common flexor tendon, medial epicondyle versus common extensor tendon is at the lateral epicondyle. Cubital tunnel syndrome you can get where there's compression of the ulnar nerve in the cubital tunnel as it's passing behind the medial epicondyle. So obviously if you have compression of your ulnar nerve, you're going to have numbness and tingling in the ring and little finger just because of the distribution of innervation of the ulnar nerve in the hand. Dupuytren's contracture is scarring and fibrosis and shortening of the tendons of your fourth and fifth digits. You'll see that it starts off with a nodule, which then forms into a rope-like cord, and as it shortens, it causes flexion of your fourth and fifth digit, such that this is the patient's hand at rest. They cannot fully extend their fourth and fifth digit. We don't know why this happens. We just know that it's, so the shortening, thickening, and fibrosis is from it occurs on the palmar fascia in aponeurosis, and the only way to fix it is for surgery where you have to cut out the fibrotic parts and then sew it back up, and hopefully they can have free range of motion in their hands again. They think it's hereditary, but they're not quite sure. So other clinical correlations that were mentioned. So you have Volkmann's contracture, which is caused by ischemic muscular, which is an ischemic muscular contraction of the fingers and wrists, resulting from ischemic necrosis of the forearm flexor muscles. So when you see ischemic necrosis, that means that they no longer have blood supply, or they have lost blood supply. And so the muscles have now died. So necrosis is like the death of tissue. Carpal tunnel syndrome is caused by compression of the medial nerve in the carpal tunnel. This can be from inflammation of the flexor retinaculum, which remember is the roof of your carpal tunnel. It's going to lead to pain and paresthesia in the hand, specifically in the distribution of the median nerve. So that first and second lumbrical and the thenar eminence, so your thumb, index, and forefinger, you would expect to have pain and paresthesia in that area. And then your handlebar nephropathy you would have from a person who rides long distances on a bicycle. You're putting pressure on that hook of hamate, which is then going to compress the ulnar nerve, because remember, it is running pretty close to the hook of hamate. So you're going to end up with sensory loss once again, and the distribution of the ulnar nerve, and weakness in the intrinsic muscles of the hand. Okay, so that was really long. Thank you for staying in there with me. I hope this was under an hour. We're gonna find out pretty soon. So good luck studying. Please remember to sleep. You encode memories when you sleep. So when you sleep, you're actually helping yourself remember stuff for your test. Take breaks. You're way more likely to remember stuff and process stuff better when you're not as tired. Remember to breathe, stay calm. You guys can do this. I believe in y'all. So good luck. And hopefully you will find this helpful.